Just I'm doing transthoracic echo of 50 years male patient having a palpitation, recurrent palpitation and shortness of breath on exertion and sometimes chest pain on exertion. And he had history of a recurrent stroke as well. And ECG shows the atrial fibrillation with first ventricular rate. And here parasternal long CV showing the interventricular septum and also infraposterior wall. Both the walls are thickened, hugely thickened. Already measured interventricular septum 17 or 18 millimeter thickness and infraposterior wall 14 to 15 millimeter thickness. Patient is normotensive. And there is no previous. This is the chest X-ray. Left, right, and left atrium. Both the atriums are dilated, and regards moderate, at least moderate regards, mitral regards, and tricuspid regards. And interventricular septum, there is a sigmoid shape and usually thickened, shiny, and there is a jerky movement due to atrial fibrillation, and there is a reduced relaxation velocity in the medial annulus and also lateral annulus as well, but significantly reduced in medial annulus. We have to try here just velocity. Okay, in the medial E prime velocity 2.43 centimeter per second, and A prime velocity 5.3, and A prime medial 0.5. Usually normal velocity more than 7 medial, and lateral more than equal or more than 11 normally. Here also reduced lateral annular velocity significantly. Lateral E prime 2 point, almost equal. So grossly we have seen there is a loss of diastolic relaxation velocity of the especially in the septum muscle, and there is a hypertrophy, asymmetrical septal hypertrophy, more thickening interventricular septum if we compare with the posterior wall. Posterior just we will say is the posterior wall thickness 15 millimeter, and interventricular septum thickness 17 millimeter. Now we have to see, is there any pericardial effusion? There is no pericardial effusion. So what are the possibilities here? There is the biatrial enlargement and moderate, at least moderate regurgitation of the tricuspid and mitral valve as well. There is a thin layer of pericardial effusion, and patient is normotensive, and there is no previous history of tuberculosis, and X-ray shows there is no pericardial calcification. So in this scenario, patient having atrial fibrillation, recurrent atrial fibrillation, sometimes the first ventricular rate after getting treatment, sometimes the ventricular rate is controlled. But in that in just 1 hour ago, ventricular rate is so fast just after getting beta blocker to reduce the heart rate. So in that case, restrictive cardiomyopathy we can be considered here. And restrictive cardiomyopathy, so many causes, genetic causes, autosomal dominant variant, autosomal recessive variant, and X-linked sometimes, and also some infiltrative disease like amyloidosis, sarcoidosis causes restrictive cardiomyopathy. So finally, confirmation of either the amyloidosis or sarcoidosis, the histology or CMR, sometimes multimodality imaging is required. That we have to just subcostal window. Here the inferior vena cava, collapsibility of the inferior vena cava, পাটাই করেন, ভাঁজ করেন, তো পাটা ভাঁজ করেন, পাটা ভাঁজ করেন। Loss of collapsibility of the inferior vena cava. If we measure, then this is the inspiration 15 millimeter, and this expiration 20 millimeter. So 50% or more reduced during inspiration, and lumen, but here lost significantly. There is no shunt anomaly, so vena cava is dilated, and this is looks like playboy sign or deer horn sign, playboy sign or deer horn sign due to tricuspid regurgitation and congested vena cava and hepatic vein as well. Okay. So up to this we can consider the restrictive cardiomyopathy, and otherwise by confirmation etiology, some biopsy or CMR, multimodality imaging, and biopsy or genetic study. There is no family history such type of illness in his family. Due to atrial fibrillation, there is a mitral velocity and diastolic dysfunction. It's not exactly we can measure in this year. Due to atrial fibrillation, it's not adequately measurement, not accurate is well. So we can measure is there any LVOT obstruction. Just putting the pulse wave Doppler in the LVOT. And sometimes it's very difficult to localize this exact location. Yeah. No, there is no obstruction. There is a trace amount of pericardial effusion along the right atrial border. And is there any systolic SAM, systolic anterior motion of can we appreciate this image? There is no systolic, this is the diastole, and this is diastole, and this is the systole. This systole. A systolic anterior motion, can we say in this mode measurement? Now we can just okay. Thank you very much.